A very good morning to one and all present here. So today we're going to deal about the investigations and the IOL power calculation in pediatric cataract. So as we all know, opacity present at birth and involving the embryonic and fetal nucleus is congenital cataract, whereas that which develops from infancy to adolescence is the developmental cataract. And based on a meta-analysis, it is said that the prevalence of pediatric cataract is said to be highest in Asia with around 8 per 10,000 children. Before we move on to the investigations, it's important that we know the causes for unilateral and bilateral cataract because the investigations are also going to vary according to that. So unilateral cataract can be like mostly idiopathic or associated with ocular anomalies like burst in fetal vasculature or posterior lenticonus, retinoblastoma, etc. Whereas bilateral is predominantly like hereditary or familial cause and associated with systemic syndromes like craniofacial anomalies, renal syndromes, and the Loeys-Alport syndrome. However, in India, if we see, the most common causes are idiopathic, 65%, followed by hereditary cause, 23%, and then the non-hereditary causes. So why, when, and whom, and what to investigate the children? So why we have to investigate is, first, preoperatively, it becomes essential that we identify the etiology so that we'll get to know about the prognosis and we can explain the same to the parents. And also we can consider for genetic screening if there is any hereditary disorders that are being identified. So usually unilateral cataracts, they usually don't have any systemic association. Then then we don't have to evaluate systemically. If there is a bilateral cataract with a positive family history and no systemic association, no need for laboratory evaluation. However, if there is a positive family history with systemic association, or if there is no family history, then we have to evaluate the children. So if we don't know where to start, we can get clues from the ocular examination itself. For example, if we see a subluxated lens, we can think of Marfan's or homocystinuria, or a corneal opacity, we can think of Peters, microcornea as in case of rubella or torch infections, posterior synechiae as in case of uveitis, and vessels on the lens as in case of Western fetal vasculature. Additional investigations also might be required, like ultrasound B scan, when you're not able to see the posterior segment. And some clues can be got from the morphology of the cataract itself. Due to lack of time, I'm not discussing everything. So most importantly, like total cataract, we have to think about Downs or bilateral dense, chalky central nuclear cataract. Then think of congenital rubella, where there are associated cardiac features also. So we have to do an echo or IgM antibodies for the torch titers. And similarly, if we are seeing membranous cataract, here we can see that the anterior and the posterior lens capsule are almost fused together. So this can mostly seen in congenital rubella or leptospirosis and Loeys oculocerebrorenal syndromes. And we can't afford to miss the Wilson's disease, where we can see a sunflower cataract. So we have to look for a KF ring, and we have to do ceruloplasmin 24-hour urinary copper, and in CBC look for anemia and aminoaciduria. Whereas myotonic dystrophy patients, they might require very importantly pre and post-operative care. Like in homocystinuria, they are more prone for thromboembolism. So we have to ensure early mobility of the patient post-operatively and look for other features in the cardiac abnormalities. So here we can see the anterior lenticonus, which is which can point towards Alport syndrome or Loeys syndrome. And here we can see a subluxation. This is the myotonic dystrophy. So we can take clues from ocular and ocular examinations. However, if we're not able to identify etiology, there can be a library of tests which can be used. Like, so most commonly we can use the urine for reducing sugars or serum calcium and phosphorus levels to identify the hypoparathyroidism. The blood sugars levels can point towards diabetes, and the torch titers for identifying any infectious etiology. So apart from the investigations to identify the etiology, there are some investigations for general anesthesia for the children, like CBC, blood sugars, hemoglobin, and chest X-ray. However, the rest of the panel is left to be decided by the anesthetist for giving fitness and the pediatrician to rule out any acute illness for the children. So coming to the second part of the talk, there is biometry. So why we can't use what is normally done for the adult eyes is because pediatric eye is not just a small adult eye. So here there's a measurement challenge in the axial length and the keratometry values. And there is going to be a myopic shift, which is very important for us to deal when we are going to do the surgery, because it can cause late refractive surprises as the eye grows. And we have to very importantly choose the IOL power formula. So biometry encompasses three variables like keratometry, axial length, and the IOL power calculation. So coming to keratometry, usually the children have very steep cornea, which as age increases, it becomes a little flatter. 48.4 by 3 years, they reach the adult value of 42.9. And the gold standard for measuring the keratometry is the optical biometers. However, if they are uncooperative babies, then we have to do it under GA by using the handheld keratometer, which is done without the use of speculum and as soon as the induction of anesthesia is done. So a few studies reported that the keratometry values of younger children were steeper than that of the older children, and keratometry values of unilateral cataract were steeper than bilateral cataract. And the cataractous eye of unilateral cataract, it is steeper than the other eye, which is a normal eye also. So next is axial length. So at birth, the axial length is only around 16.8 millimeter. And as the age increases, it's going to be progressively increasing. And most of the changes in the axial length occur within the first 2 years of the life. So this rate of axial length growth has 3 phases: a rapid postnatal phase, a slower infantile phase, and a slow juvenile phase. So this rate of axial length growth is higher at a younger age and is rapid in unilateral cases of pseudophakic children compared to that of bilateral. Study by Rupal H. Trivedi et al. Said that the axial length in Caucasians is shorter and in girls also is shorter, and the axial length in cataractous eyes is smaller than the normal eyes. So the measurement of the axial length can be either by ultrasound biometry or by optical biometry. Ultrasound has immersion and applanation. So ultrasound biometry uses the ultrasound waves to obtain the optical parameters. There are 2 types here, immersion and applanation. So coming to applanation A scan, so here it is a contact biometry. So we are going to compress the anterior chamber depth. The lens thickness remains the same, but because the anterior chamber depth is getting compressed, it is going to yield a shorter axial length by 0.24 to 0.32 millimeter. So when the axial length is told us to be shorter, we have to converge the rays now. So it will be like we have to add plus, it will show like a falsely +1 diopter stronger IOL than required. So this is going to, when we are adding more plus power to the eye, it is going to induce more convergence, and there is going to be a post-operative myopia. And this corneal compression is more likely in pediatric eyes because of the low corneal lens scleral rigidity. Whereas this error of excessive pressure can be avoided by using the immersion A scan, which is the gold standard to measure the axial length under general anesthesia. And the reading with the highest anterior chamber depth will be included for the final measurement. So we are saying it is very important that we have to accurately measure the axial length accuracy. So why accuracy is important is because even a 1 millimeter error in the axial length can lead to around 3 diopters of postoperative refractive surprise. So in shorter eyes, the error jumps to even 3.75 diopters postoperatively. So optical biometers are known for their accuracy. So applanation A scan produces like minus 0.24 millimeter because, as we told, there's going to be a compression. So the axial length is a little shorter. And IOL master gives plus 0.01 millimeter of accuracy. So here, as we can see in optical biometers, the axial length is measured from the corneal vertex to the RPE at the macular center. Whereas when we use the ultrasound ways of measuring, it is not measured from the macula, it is just perpendicular to where the rays go. So there can be a possibility of a staphyloma surprise postoperatively. IOL master, in addition to the optical biometry, it offers OCT imaging also across the entire length of the eye. So there we can measure the axial length, the white to white, the keratometry, and anterior chamber depth, the pupil diameter. So this is just a small comparison of the optical biometers. So while comparing optical biometry versus the ultrasound, it is said that the IOL master measurements were slightly larger than the contact ultrasound as expected. So here the investigation of choice becomes, here what we follow is for cooperative children, we do optical biometry with IOL master 700. And for non-cooperative and younger children, it's the immersion A scan with handheld keratometry under general anesthesia. In optical biometry, if it's a mature cataract, coloboma, or nystagmus where the axial length is not very accurate, we can use the immersion A scan with keratometry values of IOL master or handheld keratometry. Or in case of corneal scar where we're not able to get the keratometry readings, then we can use the keratometry values of the other eye also. So coming to IOL power calculation, we have to mainly discuss about the prediction error, the formula used, and the undercorrection in the IOL powers. So coming to prediction error is the predicted target refraction minus the actual refraction. Suppose if we want to target a refraction of +5 postoperatively, but postoperatively when we see the actual refraction is only +4, the prediction error is going to be +1. So IOL formula. Earlier, the IOL power formulas were based only on just on the axial length. If this is the axial length, this is going to be the IOL power that we are using based on Dahan et al. But recently, in 2024 published JCRS article, there are a lot of IOL formulas available even based on the artificial intelligence and ray tracing. But when it comes to pediatric group, it is mainly the SRKT and the Hoffer-Q and Barrett's that we are mainly using. So various studies have suggested that so-and-so formula has shown accuracy in their studies. But as such, no single formula is accepted, and theoretical formulas are preferred over the regression formulas like the SRK. And in patients younger than 2 years old or with axial length less than 21 millimeter, SRKT formula were relatively accurate, and Barrett and Hedges were better in patients older than 2 years or axial length more than 21 millimeter. There are also online IOL power calculators available like the McClatchy pediatric IOL calculator and the Piggyback pediatric IOL calculators. So the protocol is, suppose if we are using a PAC scan or an immersion A scan, for short eyes less than 22 millimeter, we can use Hoffer-Q. For normal and long eyes, SRKT. And while using optical biometers like IOL Master, short eyes Hoffer-Q and normal and long eyes Barrett Universal 2. So undercorrection in IOL power is a very important concept. Why do we have to undercorrect? Suppose if this is the axial length at the time of the surgery and we are going to correct it, later when the eye grows, it is going to lead on to a myopia because the rays are going to focus for the same power. So it is going to lead to a myopia. So what we do is we have to expect the how much axial length it is going to achieve the emmetrovization and initially make the baby hyperopic and correct the hyperopic with the glasses. So later, when the emmetrovization occurs, the IOL power is going to be appropriate. So this undercorrection can be in percentage based on age, which is Dahan et al., which is predominantly used like less than 2 years, 20% undercorrection, 2 to 8 years, 10% undercorrection, more than 8 years, there is no undercorrection. So for example, if we take the axial length as 22 millimeter and an age of 3 years, where we expect a 10% undercorrection, IOL power is 20.5. So 10% of 20.5 is going to be 2.05. So that we have to subtract from the IOL power, that is 20.5 minus the 2, which is going to be 18.5. So that will be the IOL power that we are going to implant. So undercorrection based on age and diopter. So if this is the age, this is the amount of dioptric undercorrection that we are going to do. And now the recent thing is undercorrection based on postoperative refraction. That is the target refraction, we call it. So target refraction is 7 minus age. So suppose if the age is 3 years, so 7 minus 3, it will be +4. So NAD et al. And Trivedi-Wilson et al. Are most commonly used. So if this is the target refraction, so this is called the rule of 7. So based on the target refraction, we have to decide the amount of undercorrection. So directly, we cannot subtract the target refraction from the IOL power. And various guidelines suggested by NAD et al. May achieve an acceptable refractive error at 7 years of age, but in children less than 2 years, more hypermetropia may be observed. So how to do this undercorrection based on the target refraction is, suppose when we are entering all the values of axial length, keratometry values, and the A constant of the IOL, and we enter the target refraction is 0, the IOL power is said to be 22. Suppose for this patient, if the target refraction is 4, so age is 3 years, and we are expecting a target refraction of 4. So we have to enter the target refraction and see for the IOL power. We cannot directly subtract 4 from the 22 and enter the IOL power as 18. So undercorrection based on a spherical error of the other eye. So in children 2 to 4 years, 1.25 diopters less power than the spherical error of the fellow eye. And in children more than 4 years, we can match the spherical equivalent refraction of the fellow eye. And undercorrection based on laterality. Unilateral cataracts always have this concept of amblyopia. There will be a stimulus deprivation amblyopia already in that patient. And we saw already unilateral cataract, there's going to be a higher rate of axial length growth also. So this is going to lead on to a higher myopic shift. So this requires more undercorrection than what we are going to usually do. But if we are going to undercorrect more, this is going to cause anisometropic amblyopia in the postoperative period because it's a unilateral cataract. So hence we have to balance between both and a lesser undercorrection to ensure not more than 2.5 to 3 diopters of anisometropia is there. And lastly, undercorrection based on axial length, like larger eyes tend to grow at a higher rate. So accordingly, we have to take into consideration for the IOL power calculation. And amblyopia. Amblyopia treatment is going to be easy if the anisometropia is less or the power of glass is less. If it is myopia, it's easier to tackle, and if the compliance is going to be good. So if there is a presence of dense amblyopia already, lesser hypermetropia is going to be preferred in the postoperative period. And if one parent is myopic or both parents are myopic, we have to expect that amount of myopia probability in the children also, and undercorrect accordingly. So the flow of process usually is scan, IOL power for emmetropia, and then the undercorrection based on the age, the status of other eye, visual acuity, the family history, and if any site of fixation is required, then we have to do appropriate adjustment. So this is the Delphi consensus, which has suggested almost what we have already discussed about the investigations, the comparing the applanation and immersion, and about the target refraction. Thank you.